Hello, everyone, and welcome to Behind the OR, the Peter Surgical Podcast channel, where we invite experts to reveal to us what's happening behind the closed doors of the operating room. Together, we will explore surgeries and procedures and discover more about a surgeon's life in their daily mission. Take off your gloves, take a breath, and let's talk behind the OR.
Good morning. Welcome to Behind the OR, the Peter Surgical Podcast channel. We are here today with Dr. DIAB. Hello, Dr. DIAB.
Hello, Lorette. Thank you for having me here.
Thank you for coming. And today we are going to speak about minimal invasive surgery. So firstly, can you introduce you?
I'm Mahmoud DIAB, Chief of Department of Cardiac Surgery and Cardiovascular Center, Rothenburg and the Fulda in Germany.
Thank you. So firstly, what means minimal invasive coronary artery bypass surgery?
Minimal invasive coronary artery bypass grafting means performing CABG through mini thoracotomy and not through a stenotomy. Originally, it was described for performing left internal thoracic artery to the left anterior descending artery of the heart.
Okay.
Yes.
And why a minimal invasive approach?
Because, some patients are afraid from stenotomy.
Okay.
We decide with the cardiologist as a heart team which technique for the patient is better, either PCI or CABG. So some patients, despite the decision of a heart team, do not want to have stenotomy.
Okay.
So this is a good alternative to stenotomy, CABG through stenotomy. It should not replace completely CABG through stenotomy, but it's a good alternative to it.
Okay. So what are the advantages of this approach for you and for the patient?
The most important advantage for the patient is to avoid stenotomy, and this means rapid recovery, faster recovery than stenotomy. Patients does not have stenotomy, so he can return back to sport, to work more rapid than stenotomy patient. For the surgeon, it doesn't have advantage for the surgeon. It's more work, more concentration than the stenotomy.
Interesting. And what is the proportion of minimal invasive approach versus a stenotomy for you in your OR?
Well, the proportion is rising through the years. As I started, it was like 10% of my patients, my CABG patients, and now it is by 20 to 25% of the CABG patients I perform, not for the whole center, but the CABG patients I personally perform.
Okay. So do you perform minimal invasive approach on specific patient population, or everyone can have a minimal invasive approach? What is your criteria?
Well, there are some criteria to select patients for minimally invasive CABG. First of all, the target vessels should be good in the periphery, because in the mixed CABG, we target the vessels at the periphery.
Okay.
Second, the left ventricular ejection fraction. With poor ejection fraction, it's difficult to do mini thoracotomy. Adipositas was a contraindication, but now it's an indication, because it is possible technically to do it for adipose patient, and they are the patients who benefit most of this technique. When we avoid stenotomy in these patients, it's much better. The lung function. We perform this technique with single lung ventilation, so the other lung function should be good enough to compensate.
Okay.
During the operation. I don't think there are other contraindications for this. Special groups of patients benefit from this operation, like elderly patients who are fragile. They want to go back to their normal activity soon after the operation. Other patients who benefit from this approach are younger patients who are working tough jobs, who have tough jobs. They work hard in building or driving trucks, so they benefit from avoiding sternotomy.
Okay. You mentioned that it's some patient wants to have a minimal invasive approach to go back to work faster, easier, etc. But what are the results? What are the real benefits in terms of surgery?
This is a very good question, because the aim of CABG is to perform bypasses that last for a long time. And this minimally invasive approach should not interfere with the quality of the anastomosis.
Yeah, okay.
So until now, the results are very good. We also published our learning curve. There are very few graft occlusion or reintervention. And I started this technique in 2016, and since 2016, I didn't have a patient again for reintervention or graft occlusion in follow-up. Of course, we do not do follow-up for the patients regularly, but we become again the patients we operated.
And so what is the biggest technical changes for you versus a sternotomy?
Of course, it's a challenge. You do CABG through a small incision. It's at the beginning it was unusual, and with the time we're getting better, we're getting faster, and we can do 3 or 4 vessels through this incision. At the beginning we started with 1 or 2, and then we increased now to 3 or 4 bypasses. So actually it's performing the anastomosis itself. It's not different than from sternotomy, through sternotomy, but preparing to do the anastomosis is what
different.
takes time.
Okay.
Yeah.
Perfect. Thank you very much.
You're welcome. Thank you.
Thank you, Dr. Diab, for coming, and see you in the next episode to have more technical information about minimal invasive coronary artery bypass grafting.
You're welcome, Red. Thank you. See you later.
Let's meet at EX 2024 in Lisbon on the booth 230 to discover more about surgery, education, and innovation.